Hello, everybody. Today, for my position paper topic, I'll be covering healthcare analytics. And my topic statement is effective regulation of AI-driven predictive models in healthcare is necessary to safeguard against algorithmic bias, increase trust, and ensure patient safety. I'm Mary Miron. To start things off, I would like to mention some statistics here. 94% of healthcare organizations say AI is a core part of operations. 57% of healthcare leaders have concerns over privacy, and 49% of leaders have concerns of AI bias when it comes to medical outcomes. So, healthcare as a domain requires high levels of precision, making fairness and the reduction of bias essential for equitable outcomes. And fairness in healthcare comes down to ensuring equal access and opportunity to positive outcomes, regardless of demographic and socioeconomic factors. The adoption of AI in healthcare has created challenges on an ethical and operational level around algorithmic bias. My position paper makes the argument that a structured approach to risk classification, regulation, and stringent oversight is required to mitigate bias and ensure patient safety. To give you a little bit of background, AI has had substantial contributions in healthcare, evidenced by fields such as medical imaging and precision medicine. A subset of AI called deep neural networks is utilized very commonly in healthcare, in which the approach is it propagates a signal through multiple layers of transformation, resulting in more complex patterns being uncovered. And this is very crucial because in healthcare, the data is very complex, and this approach is needed to come up with actionable insights and predictions as a whole. And then emphasizing effective regulations addresses one of the model's shortcomings, which is called overfitting. And overfitting uh, describes what happens when a model performs well on a data set that it's trained on, and how this practically translates into the healthcare setting is for the data it's trained on, it may correctly predict a high percentage of correct diagnosis or a disease. But when a model is overfit, what actually ends up happening is when it's applied to new data sets, um, a new data set may result in significantly less percentage of predictions for medical condition or disease. This is how it would be applied if it was applied to a new data set as a whole. Some issues, or the main issue, should I say, is bias leads to misdiagnosis. So bias in healthcare can be grouped into three categories effectively. So one is data-driven, two is algorithmic, and three is human bias. And the consequence of bias is something that's non-trivial because it leads to the misdiagnosing of certain ethnic minority groups. And to make meaningful predictions, AI needs a large amounts of data. And with a shortage of data from several ethnic groups, prediction results can categorize minorities as low risk simply because there's just less historical uh, evidence of them being susceptible to perhaps a disease or various symptoms. And a lack of data augments a very big data collection issue because it shows incompleteness, which threatens data integrity. Um, One study that I've addressed in this position paper, just to show an attempt to kind of actively eliminate bias, or how researchers try to actively eliminate bias when it came to healthcare as a whole or healthcare expenditures, was healthcare expenditures for Black and white adults in similar living conditions. So the participants of the study were 7,062 Black and white adults from 2,238 out of the 2,247 census tracts with a 5% or more Black population. The measure in this study that was used was called Index of Concentration at Extreme, which was used to show the racial and economic segregation across different quintiles. And over here, I've kind of represented what these quintiles are and what the breakdowns look like. So what you'll see for Q1 is mostly low income and Black neighborhoods. And then Q3 is neighborhoods with no clear privilege or disadvantage. And then Q5 is predominantly high income white neighborhoods. And the results of the study, as well as the implications when it comes to effective regulation, it showed disparities in healthcare healthcare expenditure was virtually non-existent when Black and white individuals were in similar living conditions. And what it suggests is that less historical data on Black patients' spending may be interpreted as needing fewer resources or having less severe symptoms for medical conditions from the AI prediction perspective. And then this ultimately highlights how AI trained on an imbalanced data set can misrepresent a patient's healthcare needs, which ultimately risks their safety. And an example of bias in a prediction task was a study in New Zealand. So this study was titled Data and Model Bias in Artificial Intelligence for Healthcare Applications in New Zealand. To give you a bit of an overview, two data sets were utilized in the study, which was EHR data sets, tabular plus freeform, from clinicians and general practices, and it consisted of over 9,000 plus samples. The ethnic groups in the study were Maori and Pacific Islanders, which were considered protected groups, and Europeans were considered the privileged group. And in this study, there was three prediction tests. One was patient harm, two was preventable harm, and the third one was preventing hospital mortality. The metric used to quantify bias in the study was disparate impact. So to give you a bit of context, what disparate impact means is it compares the proportion of individuals that receive a favorable outcome for two groups, a majority group and a minority group. And to kind of interpret the results, I've made this table on the left. So a score of less than 0.8 just implies the prediction bias against a specific group. And then a score of 1.25 implies bias in favor of the specific group. And then 1.0 means there's no bias. So the results of this study was that using a subset of the data for task two, it showed bias indicated by the DI scores of 0.74 and 1.25 for the Maori and Pacific Islanders, and the interpretation of the results in the context of effective regulation. So essentially, if there is no intentional effort when it comes to eliminating bias, results could be potentially detrimental with a larger EHR sample size when AI models are deployed at scales. And then even for models that have utilized data sets in which there was an active effort to eliminate bias, still need additional vetting to see the performance post the bias elimination. Another issue I wanted to point to was large corporation data collection interests. So acquisitions such as Google acquiring Fitbit and Amazon acquiring One Medical has ultimately increased their influence in AI technology and healthcare space by simply just giving them increased access to data. And then due to loopholes in the HIPAA law, monetization of healthcare data is technically not illegal. And the ability to monetize healthcare data increases the chances of AI development in healthcare to have a core focus on collecting volume of data and maximizing profit. And effective regulation in the form of oversight is needed for two reasons. The first one is to ensure that profit and scalability are not the focus over positive healthcare outcomes. And then the other thing is that acquisitions create tricky situations where data control is transferred into other jurisdictions. A very specific example of this that I identified in my position paper was Google taking over DeepMind, which ultimately gave them access to kidney injury data. And my counter argument is increased bureaucracy stifles innovation, or it'll be result in situations of stifling innovation. So effective regulation, stringent regulation can bring additional bureaucracy and red tape, as there will be a constant concern for compliance and documentation, as well as audits, which constantly puts companies in high pressure situations, just really aiming to do things right all the time. And what this then does is, smaller corporations, they have access to less capital, legal teams, and talent, which actually could create a compliance monopoly for larger firms simply because they have the expertise as well as the capital, more importantly, to navigate these complex issues as a whole. And a compliance monopoly may actually further contribute to large tech firms like Google, Amazon, IBM having disproportionate levels of access to data, which ultimately means that there's a higher chance of it being more profit driven because obviously these organizations are publicly traded and they have obviously shareholder interests, which could potentially lead to a conflict of interest in some scenarios. Not all the time, but it is still something that could potentially happen. And then AI is a black box problem. So what this means is a lot of AI is actually not really understood. And even if there was a situation where effective regulation was mandated in terms of the diversity of data sets, some predictions may be unexplainable because the foundation of AI is based off the human brain. And just like the human brain, a lot of the phenomenon is still things that science actually cannot explain. And the rebuttal to this is the counter argument, should I say, is that the EU has an AI risk framework to provide transparency and decrease consumer risk. So in the EU, AI systems are classified into four categories based on their impact affecting human rights and safety. Um, the first category is high risk, second, low risk, third is limited risk, and then fourth is minimal to no risk. So this framework can serve as a blueprint for strategic oversight without actually stifling innovation because it mandates documentation and logs for both the deployer and provider at various stages prior and post adoption of the AI model. And the reason this provides a balanced approach is that it actually fairly assigns a low and high risk depending on the severity of the task in healthcare. So how this could be practically applied is for drug discovery applications, non-clinical research, and early stage clinical trials. These are categorized as low risk. But when it comes to AI clinical decision support systems, these are categorized as high risk because of I guess, the level of decision that they have to make, as well as the potential detrimental outcomes that can happen as a result of this specific task. So now if we compare the US's comparatively lax regulations, these are some consequences here, is that the US has comparatively weaker oversight of AI in healthcare compared to the EU, increasing the risks in healthcare. So the regulation is split amongst the FDA, HHS, and HIPAA, and they have more flexible reporting windows for data breaches. A very prominent example of how I guess comparatively more lax regulation had some consequences was a US sepsis prediction model, which was adopted at scale in over 100 hospitals. Um, when it was analyzed further, what they determined was that it poorly performed with a area under the curve of 0.63. For a little bit of context here, 0.7 is considered a score that is acceptable. And if you get a score that's 0.5, that means when it comes to prediction, it's a 50-50, or in simple terms, it's the flip of a coin on how accurate it can predict outcomes. Obviously, for healthcare being a industry where precision matters a lot, this is a very concerning thing that's been observed, and the performance overall is something that's not really good. And obviously, if there's regulation around this that addresses the specific cause, uh, that could potentially be the difference between lives being saved or not. And HIPAA's 60-day breach notification is a policy reflection on low compliance because it creates catastrophic for outcomes for patients and threatens integrity because it's a very kind of large window that healthcare organizations have, and within 60 days, a lot of things could potentially happen. And then EU's GDPR having a 72 our breach reporting requirement enforces greater accountability and actually reduces the chances of data integrity being compromised. And if we compare the Europe as well as the US in terms of business digital index statistics, what this is essentially is it's real-time security rating based on external data sources. What you see is that European companies 21% score an F and 27% scored a D, and the US 34% scored an F and 31% scored a D. And just to kind of highlight another issue, which is the lack of trust, I wanted to kind of go over current physician and AI use and healthcare trust perceptions. So there was a study conducted post COVID-19, which was from April 1 to January 31, 2024. Essentially, it was 4,400 and, or sorry, over 400,043 unique respondents, which were age 18 or older, who resided outside the United States. And then In this study, what they observed is that trust in physicians declined from 71.5% to 40.1%. Um, and another study that I also included to kind of show trust, but this one's more specifically towards AI being used. So this was diverse patients' attitudes towards AI and diagnosis. So in this study, it was 24 patients, and statistical weighting was used to reflect the US demographics split. And it consisted of mock vignettes, and physicians of various specialties were consulted, such as pulmonology, cardiology, and hematology. And then what the results were was 41% chose an AI clinic, and 52.9% chose a human doctor. And when extending this to effective regulation in the form of education and transparency, what we can kind of interpret is that significant resistance in the use of AI, making a case for more transparency on model limitations and educating patients on AI in healthcare could actually potentially counteract the decline in trust. And some conclusions based on this position paper was that effective regulation to ensure fairness and patient safety comes down to constant improvements in data quality, variety, and data integrity requiring testing at various stages. And a solution to actually the lack of variety in demographic data is combine US healthcare data sets with New Zealand to prevent imbalance and data sets, and as well as skewed prediction results. So countries like the United States should adopt a similar risk classification framework to the EU based on the severity of impact, classifying as low, high, moderate, and minimal, depending on the severity of the task in healthcare. And then reducing the HIPAA 60-day reporting window to 72 hours actually makes service providers of healthcare AI deploying more accountable, because faster preventative measures increase patient safety. And obviously, with the shorter window of time, it actually just encourages the service provider, but also it keeps the patient as well aware of what the situation is, which can actually also improve the trust. And then regulating bodies such as the HIPAA, HHS, and FDA need to enforce AUC scores of greater than 0.8 to ensure that AI models are actually more than acceptable for prediction tasks. And this is imperative for healthcare being an industry which is highly intolerant of inconsistency. And this concludes my presentation for my position paper. And these are my references. Thank you so much for listening, and I really enjoyed sharing my findings.